Okay, so before I get onto the background, I just want to acknowledge this is a piece of work that was picked up at the very end of 2024, and it was a joint venture with Advanced Therapy Wales and AWTTC, with the aim of pulling like-minded people together who had an invested interest in trying to map out how we could deal with this volume of medicines that are coming through that are proving increasingly complex or disruptive, and that need careful planning and processes behind ensuring that we can implement them in a timely fashion. So I'll mention a bit later on, but a group was convened to discuss this work. So by means of some background, I think we're all aware that the NHS faces growing challenges with the increased number of complex therapies coming into play in terms of treatment options for patients. And that includes things like the advanced medicinal medicines, treatments associated with genomics and biomarker tests, and then other treatments that really require significant service redesign, reconfiguration, or medicines that have significant monitoring requirements, like some of the bispecifics, that cancer medicines that require access to intensive care beds. And all these things are putting pressure on ensuring we can implement the medicines for patients in Wales. So without that sort of insight early on, then we often find ourselves not ready to implement, and that can result in delayed patient access and inequity of access across the country. So there's a clear need, and I think it was general acknowledgement that we needed to look at how we could sort of coordinate this planning or service preparedness on a national basis, so that we could look at what everyone is doing locally and try and avoid duplication effort and bring everyone together into one place. So just wanted to highlight a couple of examples, calling them case studies. They're medicines that we horizon scanned at AWTTC long before NICE issued their final draft guidance, but medicines where there were still issues in ensuring patients could access those medicines. And one example was olaparib for a breast cancer indication that needed a new genomic test, and that was actually a pinch point for pathology service. Pathology weren't able to deliver that service, and so that had to be escalated. However, there was some delay because of the lack of sort of escalation route. So we were aware that there was an issue that was identified, but there was no sort of national process for escalation of those service capacity issues. Another example is an advanced medicinal therapy, and this will be the case for many of those types of medicines because of the challenges around those medicines and the services that are required to deliver them. Haemophilia one particularly has proved challenging for Wales to implement, and I know that one has just got over the line and has faced a number of challenges. Mavacamten was a slightly different scenario. That was for treatment of cardiomyopathy. Now that was associated with genomic test. However, that wasn't the reason for the delay to access for this medicine. That was due to the need for increased echocardiogram monitoring and the fact that health boards just weren't set up to provide that. And it wasn't until the final draft guidance was published by NICE that we became aware of that, and that then needed to be escalated. And again, there wasn't a clear route for escalation, and so another good example for why we need a national process. And then, as everyone will be aware of, the tirzepatide and the challenges with ensuring that services are in place and sufficient for enabling that medicine to get to patients who need it. So I think I've just touched on all these areas. So in terms of barriers to service preparedness and what we're trying to overcome through this national work is really that service capacity. So it could be genomics, pathology, the aseptic techniques, it could be pharmacy capacity, it could be a number of factors that really are putting pressure on the service. Or it could be more to do with service reconfiguration, such as new care pathways are needed. Could be simply that the clinics aren't set up to manage the volume of patients, that we need more ICU beds. So again, there's a number of reasons that may require service reconfiguration. Another barrier, and it's probably more relevant to some of the advanced therapy that are coming through, is that in Wales, because of the size, it's very difficult to engage in the research and clinical trials to ensure that patients are having the opportunity to access the medicines. And they're more relevant to AWTTC, since we lead on ensuring that all commercial arrangements are in place at time of NICE guidance, and also the need for blue tech forms to be completed by clinicians. Is going to be vital moving forward, that the AWTTC keep ahead of what's coming, so that those commercial arrangements and blue tech forms are in place and don't delay access at point of NICE guidance. So the group who came together came with the view or the goal or the vision that there needed to be a system in place to ensure that innovative medicines could be implemented within the service, and that there was a real need for operational planning and system preparedness at a national level. So as I mentioned, this group, or the Coalition of the Willing, that they called themselves at the time, was formed in spring 24, and their ultimate goal is to create a long-term solutions for the national implementation of complex therapies. Membership was reasonably broad but very NHS focused, and it included clinicians, planners, commissioners, diagnostic leads, and national programme representatives, with the aim to provide early insight into pipeline medicines, ensure there's efficient planning and delivery, and reduce duplication of effort. So those were the ultimate goals when they put pen to paper to try and come up with sort of a process and governance structure. In terms of how we define those complex therapies, I think we've moved again slightly from when we put this original definition down, in the sense that it's not always the medicine that's complex. It may be the system and processes that are complex that the medicine's trying to be introduced into. I guess an example would be an oral therapy that may not be complex in itself, but to get it to patients, significant service redesign is required. So we're sort of now using complex and disruptive medicines interchangeably. What we mean is it's a medicine that requires significant service sort of improvements or adaptations. I think I touched on what we mean by a new service, and these medicines must be undergoing NICE or AWMSG assessment. So the group came up with this sort of governance structure in the sense that you'd have at the bottom there 3 operational groups: horizon scanning, preparation for implementation, and commissioning delivery groups, with the aim of them doing the sort of groundwork and intelligence gathering to feed the National Oversight Panel, who'd be more of a strategic group that would have representation from all relevant stakeholders, and they'd really make recommendations to the health boards in the sense of what needed to happen to ensure timely implementation for those patients. So the horizon scanning element would be led by AWTTC, and we're currently through VPAG investment, we've currently employed two new staff who are working in this space for Horizon Scanning Cancer and non-cancer medicines on the NICE work programme. Preparation for implementation can be led by an AWTTC, NWJCC and health boards, and it needs to be a coordinated approach, and it would obviously overlap with some of the Horizon Scanning work, because it's really looking and gathering intelligence to understand what the impact of these medicines are. And then we've got the commissioning and delivery element, which again overlaps with that implementation component. All that information would feed into this national oversight panel, which will provide recommendations to health boards about what's coming and what needs to happen to ensure implementation. So I put this diagram together just to try and illustrate how I see it all coming together, and it picks up the elements I've just mentioned. So on the left-hand side, you've got that Horizon Scanning element undertaken by AWTTC. In the middle, you've got that sort of implementation and Horizons planning element. Is a medicine going to be high service impact, and to what degree? Is it going to have a high budget impact, and by what degree is again? And have the right commercial discussions taken place, and are we looking to get the blue tech forms prepared so that there's no delay in medicines access as and when a NICE advice is published. And then on the right hand side, you've got the implementation and commissioning element. And the stars I've just put on to represent where I see the feed in from the groups on the ground, where they'll feed into the national oversight panel and the complex pathways work. So I'm quite a whistle-stop tour of an overview of the work that we're currently put together, but essentially the overall outcomes or aims are to improve preparedness and faster access to these complex or disruptive medicines, ensure that there's national equity and service availability, and probably one of the key factors is to ensure there's strong strategic oversight and planning at a national level. And we're not saying reinventing anything, it's bringing the people together at the right time, in the right place, and for the right reasons, and making sure the right people get the right information, and doing it once to avoid that duplication. And through that, we feel there'll be enhanced collaboration opportunities, and that systems and stakeholders will be well linked up to make good judgments on the sorts of service and requirements that may be needed. And I should probably just finish by acknowledging that we're very much focused at AWTTC on Horizon Scanning for individual medicines on an individual case-by-case basis. But there's acknowledgement that through this work, if we really want to make a big difference, we're going to have to look at the system as a whole, because you might have one cancer medicine that needs a genomic test, but there might be a non-cancer medicine, and it's the overall pressure on the service. I picked on genomics, but it could be clinic capacity, for example. It's important that we consider the whole picture of what's coming in the pipeline and not just individual medicines. So the next steps are to take forward what we've set out here and to establish that national oversight panel. We're currently exploring existing governance structures within the NHS and how we may be able to tap into what already exists, so that we're not reinventing things, where we may be able to use skills and expertise from a group or organisation that's already in place, and then to establish those 3 operational and planning groups. We're in a good position at AWTTC because of the Horizon Scanning that's going on, and because of the support we're now involved in terms of implementation. So AWTTC are gonna move. We're looking at setting up those 3 groups and that national oversight panel.